All right, thank you for the kind introduction. So I am an infectious disease physician at Children's Hospital, Los Angeles, and I actually lead our long COVID recovery clinic. And I just also want to share that I am a hub PI at Children's Hospital, Los Angeles for the NIH Recover effort. So what I'll be talking today is really primarily discuss some recent research that has come out of Recover, which talks about the clinical characteristics of long COVID in children. And then I would like to highlight insights from our long COVID clinic at CHLA. The part from the long COVID clinic is still unpublished, but hopefully we're hoping to publish it soon. And I'd just like to highlight the ongoing pathobiology studies that I'm involved in. Again, I may not have the time for everything, but I'll try to fit it into my session. Okay, so what is long COVID? I know that the group I'm talking to, clearly all of you know about long COVID, and that's the reason we're all together. So I'm not going to spend a lot of time on this, but I really wanted to highlight the newer 2024 NASN long COVID definition that came out, which is a much more broad and inclusive definition. And it's something that we are trying to uh, include going forward. So this defines long COVID as an infection-associated chronic condition that occurs after SARS-CoV-2 infection and is present for at least 3 months, and it could be continuous, relapsing and remitting, or progressive disease that affects one or more organ systems. What makes long COVID really complex is the fact that the symptoms can affect multiple organ systems and that the symptoms can vary widely among patients. And they cause a significant impact on patients' daily activities, work, and mental health. So it makes it a really challenging diagnosis, both to diagnose and to treat and manage. So this is one of the papers that I was involved in, and this is a conceptual figure as to what happens after a COVID infection. Of course, there are a percentage of people that improve after and go back to baseline after SARS-CoV-2 infection, but various other things may happen. So the top figure here shows that someone who has underlying medical conditions after SARS-CoV-2 infection, there may be an exacerbation of the underlying conditions. Or what could happen is the persistent symptoms from the acute infections can then persist for weeks or months. And again, in some patients, there may be a period they're back to normal, and then de novo conditions can happen later. One of such inflammatory condition is MISC that occurs in children 4 to 6 weeks after they get the SARS-CoV-2 infection. So I was not sure how familiar the audience is with Recover. So a brief introduction about what Recover is. Recover is an NIH funded initiative and stands for Researching COVID to Enhance Recovery. The whole goal is to better prevent and treat long COVID in the future. Recover as it is now is an observational study and not a clinical trial or treatment study, but that is the plan for the future. And there are at least 103 sites that are pediatric sites. So Recover has an adult portion, a pediatric portion, an autopsy portion, and a congenital. So what I will be focusing on today is research that is coming out of the pediatric cohort. And more than 103 sites are enrolling for the pediatric cohort, and Children's Hospital Los Angeles is one of them. And even within the pediatric study, there are multiple different cohorts which contribute to this pediatric cohort. And of what you will see in this figure, it's primarily the main cohort that I'll be focusing on. So just to understand what happens within Recover, I said earlier that it's an observational study. There are 3 tiers of participation, with each tier having more advanced questionnaires and more depth of testing and invasiveness of testing. So the results here are primarily focused on tier 1 and primarily from the survey questions. And we do hope that as we get more information, we are able to kind of develop this research and even kind of develop what we found in terms of research index further. So this part focuses on tier 1, as I said, and compares SARS-CoV-2 infected children with those who were uninfected, with the main aim being to characterize what long COVID is. And as I said, the hope is in the future, we are able to integrate more and more data, even the lab data, and eventually refine these definition that we develop based on additional analysis. So this is really the first paper that came out of the characterizing long COVID. So what were the objectives? The objectives were to identify prolonged common symptoms that are seen after initial SARS-CoV-2 infection. And children were differentiated by age groups. So school age period 6 to 11 years old and adolescent 12 to 17 years old. And then the next question was, is it possible to form an empirically derived index where symptoms in combination could be used to help researchers more consistently diagnose long COVID? And the final question was, is there some clustering of phenotypes seen? So the study design, as I said, SARS-CoV-2 infected patients were compared with uninfected. And an extra layer of testing, the uninfected patients were confirmed to be negative for antibodies. So they were tested for nucleocapsid antibodies to SARS-CoV-2 and were negative. And more than 80 symptoms were included in the questionnaire. Questionnaires were answered by the primary caregivers for younger children and by the patients themselves in older adolescents and young adult. So if you look at this is the demographic, and I included this just to see the sample size. So the school age, there were 898 children that were included, and adolescents, there were 4,478. And as you see, there was a good distribution among male and female, and also a good distribution within the race and ethnicity. And we did have a sizable number of patients who were from a medically underserved area. And if you look at the first infected before December 1, that's 52%. That's to really show that there were patients pre-Omicron and in the Omicron era. Okay, so once the analysis was done, what were the most common prolonged symptoms in children who had a history of COVID? So there were a total of 14 symptoms that were common in both of these age groups, the school age kids as well as the adolescents. There were 4 symptoms which were more common in school age children only, and 3 that were more common in adolescents only. So this figure kind of details that. So if you see that this distinctive symptoms in the younger children, they were more likely to have refusal to go to school and fear about specific things. And also rashes and palpitations were more likely to occur in the younger children. And when we looked at adolescents, the differentiating features really was, again, symptoms related to feelings and behavior. So there was panic attacks, which was more common in adolescents, and the ENT symptoms, which included change or loss of smell or taste, and stuffy nose was more common in adolescents. And the symptoms that were very common in both of these age groups included general symptoms, feelings and behavior, symptoms including affecting the nerves and brain, hearts and lungs, stomach and intestine, and the muscles and bones. So this again just goes to say the diversity of symptoms that occurs in patients with long COVID. And what I mentioned before, the question was, could we use some of these symptoms to develop a research index? So a statistical analysis called LASSO was used to identify what the cutoff score that would be significant. So this is for the younger children. It was found that a score greater than 5.5 was more likely to be identifying PASC. So each symptom here has a score, and you add up the scores. So really, if the score reaches greater than 5.5, that means it's more likely to be PASC. And again, we have to be very careful with this kind of scoring. Long COVID being such a complex disease, it's not really possible for any score to completely capture this. But this is something which helps in research and makes the results more generalized. So that was the real purpose of developing this score. And to further test this score, we found that higher PASC research index score was associated with lower quality of life, lower physical health, and lower overall health, which makes sense, which is what you would see in a patient with long COVID. So similarly, this similar research index was looked for in an adolescent, where a score of greater than 5 was suggesting PASC for probable diagnosis. So here, if you see in the adolescents, even earlier on, change or loss of smell or taste stood out. And that by itself has a score of 12. And that single symptom would have been enough for someone to be identified as PASC. Again, the similar analysis was done comparing the PROMIS scores with the research index scores. So the higher the research index, the lower the quality of life and the lower physical health and overall health, which all makes sense. So as I mentioned before, the final question was, could we identify clusters of symptoms which you could differentiate between the different groups? And so if you see here, 4 different clusters were identified among the school-age children, and 3 clusters of symptoms were identified among the adolescents. And when they were compared, there were two clusters that were seen in both school-age and adolescent children. So one was a cluster which was many symptoms across multiple organ systems. So really a very undifferentiated kind of presentation. And the other cluster was pain and fatigue and low energy. So these clusters were seen both in the school age and the adolescents. In the adolescents, another cluster that stood out was specifically related to ENT symptoms, and there is change or loss of smell or taste. And in the younger children, we saw that trouble sleeping, trouble with memory and focusing was separated out into a cluster, and GI symptoms like stomach pain, nausea, or vomiting were more likely to form a cluster in the younger children. So that was a very brief summary of the research paper that came out from Recover, which summarized the clinical characteristics. And as I said, I also wanted to talk briefly about findings from our long COVID recovery care clinic at CHLA. So this is the way long COVID clinics run across the United States and in other countries. It's really very individualized and different. All of us have responded to this in various ways that works for our institution and the people around that. So in our hospital, it's housed in the ID division. The ID provider sees the patient for the first visit, does a comprehensive evaluation, history, physical exam, and labs if needed. And the referrals are based on the most symptoms that are most affecting the patient. And then we have long COVID champions in various divisions that serve as point of contact and facilitate referrals. This is more of a pictorial representation of what exactly happens once patients come to the clinic.
I wonder if somebody could turn off their audio so that, oh, there we go.
All right, thank you. And so really the incentive for doing this study was that there is not enough information about long COVID in children. Even identifying long COVID in children fell much behind adults. And it's known in adult females that long COVID is more frequently seen, but there's not as much information about gender differences in children. And there is very little known as to effects of vaccination on symptoms of long COVID. So our objectives were to identify the symptoms of long COVID and to see if any gender differences were present, to determine the overall symptom duration, and to observe the impact of vaccination. So this included all children referred to the long COVID recovery clinic from August 2021 to May 2023. And this was a retrospective study. And if you see here, 123 patients were included. mean age of 13 years, and there was an even distribution between males and females. They were seen at a mean of 13.8 weeks after the onset of infection. And mean duration of symptoms at presentation was 31 weeks. So that was a long duration of symptoms before even they were seen in clinic. And as you see here, the most common symptom was fatigue, followed by headache, exercise intolerance, dizziness, and brain fog. Then we looked at the differences between males and females, and there was no difference in the symptom duration between males and females, but there were some differences seen when we looked at the specific symptoms. So dizziness, brain fog, palpitations, passing out, and a diagnosis of POTS was more common in females. And if you see here, the only thing that was slightly more in male was loss of appetite, but the numbers were really small to come to a conclusion regarding this particular thing. The other thing we wanted to see was what happens to the symptoms over time. And there is overall decrease in symptom burden over time. And I just want to mention that the follow-up data is not indicative of the whole population, of the whole 123 patients. This follow-up was available only for 74 patients who had at least one follow-up. And the change, this is a representation of change in number of symptoms over time. So from the time they were seen in clinic, there was a decrease in symptoms. And if you see, the decrease happened mostly in the 6 to 12 months. And after 12 months, it pretty much plateaued. The other question was vaccination. What was the effects of vaccination? And in our cohort, 33 patients were unvaccinated prior to the onset of long COVID, and 30 patients were vaccinated prior to long COVID. So really 30 patients had a breakthrough infection, which then led to long COVID. And within our cohort, 43 patients received the vaccine after the symptoms of long COVID started. So we were really interested to see what are the difference between the vaccinated and the unvaccinated. And if you see here, there was no significant difference in the number of symptoms between those with long COVID, between those who were vaccinated and unvaccinated prior to the onset of long COVID. The next question was, what difference did it make to patients who got vaccinated after the onset of long COVID? And if you see here, 53%, that's 23 patients who received the vaccine, had no change in symptoms, so their long COVID symptoms continued. 19 patients, which were 44%, had reported improvement in symptoms after the vaccination, and a very small percent, one patient, reported progression of symptoms after the vaccination. So to summarize, long COVID symptoms occur in almost every organ system of the body, and the patterns are similar but distinguishable across the pediatric age groups. Symptoms including brain fog, chest pain, palpitation, and POTS were more commonly reported in females, and a decrease in the burden of symptoms was noted over time. And vaccination appears to have a beneficial effect in elevating long COVID symptoms in some children. And long COVID in children is a public health crisis and will likely have substantial impacts for decades to come. And identifying targets for therapeutics or clinical trials in children is vitally important. And I'll just take a minute. I know I'm probably over time. I'm involved in this pathobiology study, which is looking at viral and host genomics. The effect of the viral and host genomics on the phenotypic expression of COVID-19 infection and its sequelae. And it looks at children of varied genetic ancestries and what is the effect of the infection on children of varied genetic ancestries. This study is currently ongoing, and once we have results from this, I would be happy to present sometime in the future. I would like to thank everybody in our group who has contributed both in Recover and our long COVID clinic contributed to these findings that I could present here. Thank you.
Thanks very much, Dr. Mohandas. That's a terrific overview of the work that you're involved in. Appreciate that. I don't see any questions yet in the chat, but I did see a couple of comments about the inclusion of prevention in the overall recover approach and how the observational component actually contributed to ideas about the clinical trials. So nicely phased approach there.
Yeah.
We have a comment from James here. Thank you for the presentation. How do you think this knowledge can be mobilized to governments and to healthcare providers? So many of them dismiss or are ignorant of long COVID in children. Can you comment on the kind of dissemination and engagement
No,
with?
I think it's a super important comment. It is really sad that despite all the work that is happening on long COVID, it is truly under realized, underestimated in the general population, even within physicians. So really a lot of outreach in terms of education. So I think this kind of session is great. We also are involved in a lot of virtual sessions to educate a lot of providers and I mean, I have also been involved in a testimony to the Senate to highlight long COVID in children. But I completely agree that all of this has not been enough. I think still the understanding or the focus on long COVID, particularly in children, is really not where we would want it to be. And I think efforts like this should continue and be ongoing to highlight this problem and be able to focus more resources on to finding the pathobiology and eventually finding a fix for this.
Thank you for that. I wonder if you also might comment on just how this translates into the care for those children in your clinic in particular.
Yeah, I mean, care for the children has really, I mean, we started the clinic around 3 years back now, right? And the hope was, I mean, when we started seeing the initial patients, the hope was, oh, we are working a lot on the research and probably we'll have some answers and potentially some therapies soon, right? And that has not really happened. So a lot of what we do in terms of management is really supportive currently until we have more treatment modalities or more understanding of the pathobiology. Hopefully we'll be able to move to that. And that really highlights the need for clinical trials. And I'm sure Dominic can highlight what work is going on to that. And again, with clinical trials, right, they're likely to focus on adults. So really the push is that any clinical trials should also involve children and children shouldn't be left behind. So I think we'll continue to push for that.
Thank you. And there's a comment there that there are a few resources for children in particular. We have started to gather some, and I know that there's some excellent resources through Recover and other long COVID kids organizations. But the question here is, are there recommended treatments for those cases where improvements are not happening?
That's a very tough situation. And like even when I shared my clinic information, right? Around the 12 months mark, I feel that if children have not improved, the kind of improvement stalls, and they are the children likely to have prolonged symptoms. And really, I mean, I wish I had an answer to say that, okay, we do this and it works, but unfortunately we don't. Parents and families resort to a lot of alternative treatments, and some find help with that. But I cannot say that we have something that we offer which really helps these patients. It's really a lot of managing day to day and managing their symptoms that we really focus on.
Yeah, thank you. Just in the interest of time, I'll skip to the second part of your question, Nandini, is do you have any advice for us in terms of the trend in Canada where psychiatrists are shifting their diagnosis of children living with long COVID to somatic related disorders instead of acknowledging the pathophysiology? And also, has your team considered developing clinical guidelines for long COVID in children to support the implementation of care?
Yeah, I think really even that thing of attributing the symptoms to somatic problems, really the only way to fix this is by education. And I think what happens is a lot of the long COVID sessions are arranged by all the people who are interested in long COVID, right? So all of us get it, but really the sessions need to reach the other people who do not understand long COVID as much. So that is a challenge. And treatment guidelines, yes, we would love to work on it. I know NASM has come out with a huge report on primarily focusing on the definition of long COVID, but clinical guidelines or for management is something we really need to work on. We don't have any specific treatment guidelines, but do want to work on it in the future.
Okay, thank you very much, Dr. Mohandas. I think we'll switch now, but really appreciate your contribution today. And just so everyone knows, this session is recorded and will be posted on our website shortly after the meeting. So thank you very much. So I'm going to turn to our second presenter now. Dr. Dominique Salmon is an infectious and tropical diseases professor at Paris Descartes University in France. Her clinical subspecialties include HIV/AIDS, viral hepatitis, bone and joint infections, and antimicrobial stewardship. But since 2020, she's been primarily focused on long COVID. Dr. Salmon coordinates an outpatient management platform for patients with prolonged manifestations of long COVID and works in partnership with several research units conducting clinical studies on the pathophysiology of long COVID. So I just want to say a warm welcome to Dr. Salmon, and I will turn it over to you now. Thank you.
Thank you very much for the invitation. We are always very pleased to discuss with our Canadian cousin. And so this presentation, I did it on the last Congress on long COVID in Spain in November 2024. And it's a little updated, but if you have already here this presentation, it will be quite the same. So the next one. Do you manage the slides, Susan? Next one. So here I'm a conflict of interest. Next one. So I suggest to follow the following plan. First, presenting the symptomatic intervention very shortly. Then, what are the current trials for causal intervention? It will be the main topic of my presentation. And to finish with some lessons learned to the future. So just to precise that I will focus my intervention on pharmacological trials. Next one. So the symptomatic management of long COVID in France is based for the High Authority of Health, for which I work on 4 pillars. The first pillar is the symptomatic treatment. The second one, very important, is the information and self-management by the patient of their post-exertional malaise. The third one is the rehabilitation with a central role. I will not detail, but it's very important in either physical or neurological, etc. And third, the management of anxiety and disorder if they are present. Next one. So there are a lot of symptomatic treatment that we use currently for long COVID, for POTS, for musculoskeletal pain, for neuropathic pain, mastocytic activation, which is quite frequent in long COVID. It's not a mechanism really, but it's secondary to the inflammation, anxiety and depression, bronchial hyperactivity, sleep disturbance, etc. Some of those drugs have been tested in specific trial in long COVID, but not all. Next one. For example, you see here some drug repurposed that have been tested for long COVID. For example, the antidepressant agent, modafinil or sofriam fetal for hypersomnia, melatonin or light therapy for insomnia or disturbance of sleeps. So all the table will be like that. I will give you the name of the trial, the number of the patient in all trials, the different arms, and I will focus mainly on trials with a placebo arm, the main endpoint, and you will, in the different table, notice that the main endpoint is nearly always a clinical endpoint. We don't have yet valid biomarkers, the promoter and the study start. Next one. There are some trials already performed in the field of rehabilitation and pacing that I will not discuss, but you can see that, for example, for pulmonary rehabilitation, 2 trials have been published, and for pacing, at least 2 trials also have been published that show significant positive effect. Also, it's really a modest effect. Next one. So tonight I will rather focus on clinical trials that aim to fight putative mechanism of long COVID, either antiviral approaches, inhibition of latent viruses, inhibition of hyperinflammation, neuromodulatory approaches, anticoagulant and tissue oxygenation improvement, and other approaches. But you will notice that all the studies that I will present are very modest, mainly pilot, the lack of power, and the effectiveness is very relative if you compare, for example, with very big trials that we had in HIV or in hepatitis. And often, the main endpoint is measured at the end of the treatment, and we have no long-term follow-up. Next one. So several of, you know that several symptoms in long COVID are very suggestive of an autonomic dysfunction. And now we know that this dysfunction affects more the parasympathetic system than the sympathetic system. There is a disequilibrium between both. We don't know exactly the cause of this dysfunction. Maybe it is a consequence of the different mechanisms that are supposed to act in long COVID. Next one. So in order to look at the different trials currently ongoing, I looked on clinicaltrial.gov websites where I found at least 555 clinical studies on long COVID, among which there was 145 therapeutic trials, but only 33 testing pharmacological and causal intervention. All the other trials consist of symptomatic treatment, like ivabradine, for example, for POTS, physical and neuropsychological rehabilitation trials, supplement, photobiomodulation, etc. So it's interesting, but it's not the focus of this presentation. I also looked on CTV websites and also on PubMed if recent trials were published. So it's not an exhaustive work at all. So certainly I missed some trials. Next one. So let's see first the antiviral approaches, because the persistence of the virus in reservoir is really one of the main hypotheses. Next one. There are at least 4 trials testing anti-SARS-CoV-2 antivirals. The first one has been published. It is a stop-pass trial. The second one, so I will detail it a little. The second one is a Recover Vital trial that is testing longer duration of 25 days of Paxlovid versus 15 days and versus ritonavir as a placebo. One trial is testing oseltamivir, and another one, a very short trial, is testing remdesivir. You can see that the main endpoint in all those trials are quality of life or cognitive or clinical symptoms, but we don't have yet a virological marker. Next one. So you have all seen the results of the Stop PAX trial, which included 155 patients, mean age 33. We received 15 days of Paxlovid versus placebo, and there was negative results. You can see that in both groups, there was a decrease in symptoms, but the burden of symptoms remained high at the end of the trial, which was at 12 weeks. And even the most bothersome symptoms had a high severity in the treated arm than in the placebo arm, which could be reflects a reactivation after an efficacy, a certain efficacy of the treatment. Next one. So how to explain this failure, despite we know that there are viral reservoirs in the body in long COVID? Probably the drug that we have now is really insufficient in terms of antiviral activity. Maybe there is a poor penetration in some reservoirs. Maybe the endpoints are not appropriate because it was only clinical. Maybe the patients were too heterogeneous with old patient, new patient. And maybe the viral RNA that we find in some patients does not always replicate. And maybe it's not the only way to fight long COVID to use antiviral. However, I think it's very important to continue exploring this antiviral activity with more potent antiviral combination, antivirals that better penetrate in tissue, more prolonged duration, and also, of course, to develop valid biomarker. It's really a thing on what we work with our French colleague from INSERM and Pasteur Institute. And also have more large platform and probably develop international trials to have really a lot of subjects to be able to see if in some patients it could work, antiviral, and in other patients it could be another mechanism. Next one. So in this field, you have seen also the report of 3 cases of striking rapid remission of severe long COVID after monoclonal antibody infusion. It was monoclonal antibody Renaprev, which was directed against pre-Delta variants. So the possible mechanism of action could be neutralization or displacement of the virus, but this was not reported by other team. And there is currently one trial, short trials with another monoclonal antibody directed against all variants with, again, you see a clinical endpoint. Next one. So let's move now. We stay in the antiviral field, but what about the trial testing the inhibition of latent viruses reactivation? We know that there is sometimes reactivation of herpes viruses such as EBV, VZV, or retroviruses such as F proteins. So there is several trials in this direction. The first one is temelimab. It's a monoclonal antibody directed against HERV protein. HERV protein is a retroviral protein that reactivates in multiple sclerosis and in some patients with long COVID. So this trial was performed in patients with HERV reactivation. However, you have seen probably at the end of last year that it gave negative results on the main endpoint and also on the secondary endpoint. We don't have completely the last results and we don't have yet the publication. Some colleagues are testing antivirals for long COVID, also to test the hypothesis of other retroviruses reactivation, Truvada, Maraviroc versus placebo. Valacyclovir is also tested against the hypothesis of EBV reactivation. And lazerotide is also tested. It's another hypothesis testing the tight junction improvement in order to prevent viruses to get from tissue to the blood. Next one. So let's move now to immunomodulatory approaches. What is ongoing in this field? Next one. So there is also a lot of trial in this field. The first one was BC007. It was a neutralizing functional autoantibodies directed against G protein receptors. Patient received 2 infusions of BC007 versus placebo. However, patient had a lot of hope in this strategy. However, at the end of 2024, negative results were released. We don't know more at the moment. There is also a trial on autologous stem cell infusion. It's expanded stromal vascular fraction. I don't know exactly the rationale of this trial, but I noticed that it's ongoing on 20 patients. There is also different immunomodulators that are tested. Anakinra, it's a Greek trial for which we don't have yet the results, and a trial that you are doing in Canada with phosphodiesterase inhibitors, ibudilast and pentoxifylline, which are anti-inflammatory drugs directed against innate immunity. So it's interesting because in long COVID, there is certainly a great stimulation of innate immunity and NK cells, mastocytic cells. Next one. Always in this field of immunomodulation, there is a trial with baricitinib, a Janus kinase inhibitors, which is used as a drug in some connective disease as an anti-inflammatory drug inhibiting alpha interferon. There is also a trial with rapamycin. It's a potent immunosuppressant drug that at high dose has immunosuppressive properties, but at very low dose has rather immunoregulatory properties, stimulating also interferon and NK cells. So there is a short trial, but very interesting. And there is also a trial that will begin with maraviroc and atorvastatin that I will detail a little more. Next one. So concerning maraviroc pravastatin, I detail that because we have some publication. You know that in acute COVID, the platelets are activated and they interact with monocytes and endothelial cells to create a protraumatic environment. And in long COVID, it is the same. The one team, Patterson team, has found that there was spike protein in some subclasses of monocytes, the CD16, and that they express CCR5 and fractalkine, and that disrupt give an adhesion between monocyte, endothelial cell, and platelet. So using CCR5 antagonist and atorvastatin, fractalkine inhibitors could disrupt this adhesion. So there was a very modest study in 18 patients who received this association during 6 to 12 weeks that show a decrease in some vascular markers and also a subjective improvement in some symptoms, namely autonomic and respiratory cardiac symptoms. So it will be followed by this randomized trial. Next one. So that is my personal series. So I was really impressed by those results. And I tried paravastatin in some patients until a day where I find very interesting results in patients with severe digestive symptoms. So I presented a short series at the last conference of long COVID in 11 patients who had a lot of symptoms, but the predominant symptoms were digestive. And with this association, you can see that quite rapidly there is a decrease in the percent of patients with a severe digestive score for abdominal cramp, rectal urgency, diarrhea, etc. So some patients stopped the treatment and unhappily had a relapse, so had to take this treatment again. So I think this trial, these randomized trials oncoming will be interesting. Next one. But maybe Maraviro could not work on all patients. So we will have, maybe it will be the same for the different trial. We will have to study in which subpopulation each drug can be interesting. Let's move now to neuromodulatory approaches. Several treatments are tested against neuroinflammation. Next one. So the first one is naltrexone low dose. Naltrexone is an antagonist of an opioid receptors, and it exerts anti-inflammatory and immunomodulatory effect. It has been already tested in some conditions, such as multiple sclerosis, for example. And in long COVID, there was 2 reports, a retrospective cohort of 59 patients, in which 62% of them reported an improvement in at least one symptoms, and a little study of 30 patients in which only 62% reported a slight improvement in fatigue and in quality of life, but it's already something in a field where we don't have a lot to propose to the patient. Next one. The second drug that has been repurposed for neuromodulatory effect is amantadine. Also, it is a drug that is not used only on Parkinson's disease, but has been used in chronic fatigue and in patients with multiple sclerosis. And here it's a little trial of our Iranian colleague, which show a significant reduction in fatigue score in a little pilot study. But there was, well, you can see here before treatment and after treatment the score. Next one. So it's interesting to note that on clinicaltrial.gov website, there are at least one randomized trial with low-dose naltrexone until the patient will begin with 1 milligram, and then they will increase progressively until 4.5 milligram QD. There is at least 2 trials with amantadine, and there is also a trial for statin, for which you can see also the endpoint will be really clinical, but rather focus on neurocognitive assessment. Next one. So in this field of neuromodulatory approach, there is also a trial with lithium. There is a trial with glutamatergic modulators, 2 trials with transcranial direct current stimulation, and 1 trial recent trial on autonomic dysfunction. There is not a lot of things on autonomic dysfunction. Also, it is really bothering for our patient, but there is one trial which will test IVIG. And also, I saw some preliminary reflection on a trial on a sympathetic blockage for those patients.
Excuse me, Dr. Salmon, we're almost out of time, so I wondered if we could wrap up, but we could stay for an additional 5 minutes if people would like to ask questions.
I go very quickly. Let's
That's
go.
okay.
Okay. Next one, please. Next one. So very quickly, I will tell you that there is also a trial on better oxygenation of tissue. There was a pilot trial by our Israeli colleague on hyperbaric oxygen that was encouraging. Next one. So there is enthusiasm on this approach because you can see that there is at least 5 trials on hyperbaric oxygen therapy. So we will have results soon, I hope. Next one. Apheresis, it was enthusiastic for patient. It's a filtration-based approach to remove antibody, inflammatory, toxic molecules, etc., etc. So there is only results on the decrease of cytokine, but no results on clinical endpoints. So there was really a warning against this approach in a Cochrane review. Next one. And also there is an approach by Teresa Pretorius of triple anticoagulant therapy. So it's a heavy treatment because it's a dual antiplatelet therapy plus oral anticoagulant. But it's very impressive. At the end of treatment, there was really a big decrease of symptoms. However, it's the only team who had these results. So we really need confirmation of the use of anticoagulation before giving it to all patients. Next one, I accelerate. So just to show you that there is a randomized trial with apheresis ongoing. Next one. I think it's finished. Okay. So just to conclude, it's a field rapidly evolving with a major increase in the number of trials. So I think it's the last time I do this review because after that it will be really impossible. It's a little disappointing because up to date we have no conclusive success. However, it was really an opportunity to highlight a lot of methodological need for those of you who will build clinical trials. First, it's very important to define really the cases to limit heterogeneity due to the variability of symptoms, their severity. Secondly, it's important to homogenize the outcome. So far, it was quite imprecise and variable. You know, for example, in HIV, it was viral load or CD4 increase. So we have not yet this for long COVID. And third things, it's very important to have a longer term evaluation time. Next one. And just to finish, what seems urgent after such a review, it's a need for biomarker. You all know that several are developed, such as RNA in tissues, spike protein in plasma, cytokine profile, metabolomic profile. But so far, they are not sufficiently sensitive. But it's important to put them as secondary endpoint in trial to begin to use them. It's also crucial to multiply the trials. I think the priority would be combine antivirals, anticoagulants, restoration of mitochondrial function. But as you see, there is nothing in this direction yet. And what would be very interesting would be to build together an international consortium of clinical researchers to better define the clinical trial methodology and to make progress to do collectively larger and flexible trials like you did in RECOVER or I saw also you are doing with reclaims. And maybe in the next future, all what we do for long COVID will be useful also for other post-infection syndromes. Thank you very much.
Thank you very much, Dr. Salmon. That was a terrific overview of the clinical trial status at the moment. No small feat, of course. There was a question earlier about your thoughts about symptoms, and I'm sorry I didn't write down which, but if there were a particular group of symptoms being related to the vagus nerve. Do you want to comment on that?
I think that the majority of symptoms are related to the vagus nerves, for the autonomic system is responsible of all what is automatic in our body. It can be the cardiac variability, the respiration, the digestive symptom, the thermoregulation symptoms, the sleep control. So not all symptoms, of course, for example, cutaneous symptoms, for example, are normally not due to autonomic dysfunction, but a lot of symptoms are due to autonomic dysfunction. For example, when you have paresthesia, probably paresthesia, it's a small fiber neuropathy. Maybe it's also autonomic dysfunction. We don't know, But I think it's much more common than we thought at the beginning.
Okay, thank you. There's a question about the proportion or if there are any trials involving children, or are they all adults?
Really, all the randomized trials are adults. But I know that some pediatricians, they treat aggressively children. For example, we had an article from Buensenso, a colleague from Roma, who treat children with antihistaminic drugs, anticoagulants, but there is no, to my knowledge, randomized trials yet.
Okay, thank you very much. There is there is a comment from Dr. Chung there that there is another study using supplemental oxygen and carbon dioxide going to be submitted for publication soon, and that was in response to a question about supplemental oxygen as a therapy. So,
yes. Personally, I use that, so I don't want to insist on that because we don't have any randomized trial proving the efficacy. But from my experience, to give intermittent oxygen after an effort decrease the severity of post-exertional malaise. So I think for severe patients who are subject to severe malaise, it could be interesting.
okay. Well, I think I'll have to end it there. I just want to say a huge thank you to both Drs. Mohandas and Dr. Salmon. This has been a fabulous overview of long COVID in children and clinical trials. Thank you so much. And the recording will be up soon. And there is a short survey. Thank you, Karen, for posting that. And please take a few minutes to give us some feedback. Thanks.
Thank you very much.
Take care, everyone. See you next month. Bye-bye.